Cool, let's start. So kia ora koutou. Again, welcome to Mobile Health Evening Seminar, webinar, and welcome back for all of those of you who come in regularly. I'm Pauline Proud, I'm in Auckland. This is the Manukau Harbour behind me, and your speaker tonight is Harriet Sims, who's also based in Auckland. Now, Harriet is a registered nurse and clinical team leader at Tupu Ora Community, and that's the Auckland Regional Eating Disorder Service. Harriet's a registered nurse and a clinical team leader at Tupu Ora, and for the past 10 years, she's been working with young people, adults and their families to support them with physical and mental health challenges. Harriet has experience in providing medical and psychological treatments for eating disorders, along with experienced treatment for general mental health. So welcome, Harriet. Thank you.
Thanks, Pauline. Good evening, everyone. It's really exciting to be here. Really passionate about getting the message around eating disorders out far and wide. So I'm looking forward to this evening. So I'm just going to jump in. The focus of the presentation tonight will look at kind of more widely at eating disorders first, and then a bit more specifically about the treatment in young people. So I'm going to try and explain where we think eating disorders come from and how we diagnose them, then think a little bit about assessment and how we monitor people who might be presenting with an eating disorder, and then, as I said, specifically about young people. So I always like to start with the common misconceptions in social context that eating disorders occur within. So these are some of the really common myths that come up regularly, and you probably have heard them in day-to-day life. So one of the places I always like to start with this presentation is demystifying some of them. So a common one that's been around for a long time is that eating disorders are a lifestyle choice and not a serious illness. The idea that someone kind of chooses to have an eating disorder and that the focus of it is around looks and vanity, maybe the model aesthetic. And we know that eating disorders are actually a really incredibly serious mental illness that people don't choose to have. And another one, particularly in young people, that's a myth that often comes up is that parents are to blame, or something that's happening in the home is to blame. And we know that sometimes the family context could have contributed or be playing into what's happening, but it's not the cause of an eating disorder. And parents are actually usually our most important resource for someone getting well. Other really common one, dieting is a normal part of life. And I often get a few arguments around this one because dieting is just so prolific, particularly in the Western world, and it's just not actually a normal thing that humans need to do. So we are really anti-diet as such in eating disorder work. And then the last one, that it only affects white middle-class females, particularly adolescent girls. And the research is really clear around this, that it affects people from all ethnicities in all parts of the world and presents in mostly the same rates throughout the world as well. So it's a really, it's not a societally bound illness as such. It's present everywhere. So thinking about the social context that people are living within around eating habits and the diet messaging. So most commonly we see most people at some point in their lives will have tried a diet or done some kind of alternative eating habits. And that can be actually anything from veganism to fasting to just some calorie counting, some cutting out a food group. It'd be pretty hard pressed to find somebody in New Zealand who hasn't had a go at that at some point, and that's kind of one end of the scale. As we start to be concerned about whether that's maybe tipping over into an eating disorder, we're thinking about, is it interfering in the person's life or affecting their health? And that might be the point where we're starting to raise some red flags and be concerned. And then right at the other end, the more kind of extreme end, is someone meeting full diagnostic criteria for an eating disorder. Body image is really important to consider as well, plays a big part into eating disorders and is, can be quite culturally driven as well. So understanding that it's part of our self-image and how we view ourselves and what we think our appearance might say about us. So there's often a lot of judgments, and this can be different in different cultures around what certain parts of the body might mean. So a higher weight might represent laziness, a lower weight, something to achieve and be kind of put up on a pedestal. And we know that struggles with body image affects most people. So in this research is a little bit old now, but it just shows that thoughts about body image and worries about people's bodies affects most people, and it's getting younger and younger. And so always one of the most concerning statistics in this study was the 1 in 4 7-year-old girls having tried to lose weight at least once. So these messages are coming into people's worlds at a really, really young age. So one of the theories that we work with in eating disorders is the body positivity movement, and trying to move the judgments out of weight and size, really, and knowing that the more research that has been done around weight and what that means in terms of someone's health, the less those two things can be matched together instantly. So if I look at someone and see them as a higher weight, that doesn't necessarily tell me anything about their state of health. Same at a lower weight. So there's the real extremes that we see of the really, really low BMIs and weight, and the really, really high ones. There's likely to be some health issues going on, but everything in between doesn't necessarily tell us much about someone's health status. And my favorite, most important message of all is that diets do not work in the long term. And so really what we want is that we're getting to people earlier in their changes to food. So whether it's that they're starting to go into a more of a binge pattern or starting to go into a restrictive pattern, before people have drastically changed their BMI, we want them to start to get some really good information and education that dieting in either extreme is not effective, and it's going to lead to more issues with weight as time goes on. So what causes an eating disorder? There's lots, like many mental illnesses, there's lots that we don't know, but it's starting to become more and more clear that it's very complex, and there's a multitude of triggers and risk factors that make up an eating disorder. So we'll go into this a bit more. So some of the biological things we know is having a close relative with an eating disorder or a serious mental illness. So for example, in some of the genome sequencing that's being done, anorexia sits in a similar sequence to psychosis and bipolar. So if someone else in the family has a mental illness like that, then it's going to raise the risk for a person. Do see it more prominently in people with a female sex, and around the onset of puberty, into probably kind of late teens is the most common time things starting. Any sudden weight loss, that's often a catalyst. So most commonly people will describe either an intentional or non-intentional period of weight loss right before the onset of an anorexia. And people also have a high risk of anorexia with type 1 diabetes. There's kind of two main personality profiles if we were kind of categorizing things. So in anorexia, we tend to see more perfectionism, anxiety, OCD type behaviors, and in bulimia or binge eating, we tend to see more difficulties with processing emotion and tolerating distress, more chaotic type personalities. Sports, really kind of high achieving young people can be a risk, and we see a high prevalence of trauma, PTSD as a comorbid presentation in all eating disorders. Then kind of being in a society where thinness is idealized, and that can kind of add to the risk factors. Anyone in our rainbow communities at higher risk, and particularly people in our gender diverse communities, are seeing more and more. Not that it's kind of more prevalent, but just that people are accessing help more easily at the moment. And some kind of change in someone's environment. So whether that be like moving countries or moving schools, changes in the family structure, those kinds of things can impact as well. So we know more and more about how the brain plays into this, and this is particularly relevant to anorexia. And we often end up focusing on this a lot because of the high medical risk that comes with anorexia, although it's probably the less prevalent of the eating disorders in your kind of average community. But there's some of the things that's important to think about in terms of anorexia, and what you might hear about as a change in a person that's happening. So as I said, tend to be more obsessive compulsive traits, anxious temperaments, perfectionistic, avoidant of emotions or difficulties kind of tolerating negative emotions, quite rigid, difficulties with change, and a reduced reward sensitivity. And it's really common for people to report that starvation has a more euphoric feeling to it. So you often hear people talk about the idea of being hangry when you haven't eaten, and that's how the general population would feel. But someone who maybe has a tendency or has a risk factor for anorexia might get more of a euphoric feeling from starvation. And that can kind of then start to link into a bit of an addictive cycle for restriction. So again, in terms of anorexia, we learned a lot about the medical risks and the way someone might present from the Minnesota study that was done in the 40s and 50s, and was very unethical. You'd not get away with doing it now. But at the time, they took 36 young soldiers just post the war, and they wanted to understand what happened when somebody was starved. And so what was seen when the men were starved was very similar symptoms to what we see in anorexia. And probably the difference is when people were re-fed, the people who had the risk factors for anorexia, some of those cognitions and difficulties stayed and took longer to resolve. Whereas people who weren't at risk of anorexia, all of the symptoms resolved on weight restoration. So we know that low weight has a really incredible effect on the brain and the body, that's shutting a whole lot of things down. And so one of the most important first things with anorexia is to refeed someone, and a lot of the symptoms will disappear over that time. So thinking about the diagnoses, I'm going to talk particularly, so most services in New Zealand will treat, specialist services will treat anorexia, bulimia, and some will treat ARFID, and occasionally binge eating. There's kind of a current tension that the DHBs are still working on the DSM-4 for diagnosis, of which ARFID and binge eating aren't in, they're in the DSM-5. So it's a bit of a grey zone as to whether services are treating those two diagnoses at the moment. So I'm just going to focus on the three that we're primarily treating. So for anorexia, we're looking for restricted intake that puts someone at a body weight and developmental stage that's less than where we think they should be at, or less than what their normal is. An intense fear of gaining weight, a disturbance in the way they see their body. And then we think about the two subtypes. So one subtype is restricting and the other is binge purge. So this can often get confused with bulimia. But if someone's got low weight and they're losing weight as well as engaging in binge purge cycles, then that would be anorexia. If they're at a weight that would be considered healthy for their body, or at a higher weight and there's binging and purging, that's more likely to be bulimia. Although we take BMI into consideration, we know it's really evident that people can develop anorexia at any weight if they've had a fast and significant degree of weight loss that has triggered off the cognitions around the fear of gaining weight and disturbances in the way they see their body, then you can develop anorexia at any weight. So it's a little bit old school now to think about the categorizing by BMI. And while that's still relevant, it's just really important to consider that someone could be developing anorexia at any weight. And so that's generally referred to as atypical anorexia if it's someone that would be considered in the BMI range as at a normal weight. And so like I said, the difference with bulimia is that someone would be more in what would be considered a healthy weight for their body, and they haven't had any weight loss, or they're not actively losing weight. With bulimia, we tend to more just see some weight fluctuations, but within quite a narrow zone. So we're looking for periods of eating that would be considered more in one session than what you'd consider an average person having, and generally them describing a lack of control over that. So it's really important when thinking about assessing for that to get an idea of the amounts of food quite specifically. And then they're engaging in some kind of compensatory behaviour to try and prevent weight gain. And it's helpful to think more widely than just purging with that. So people could be doing that through exercise or through laxative use or some other way of trying to get rid of that food. Concerns about weight and shape, but usually not as intense as in anorexia. And in terms of thinking about severity, we're thinking about how often these episodes are happening in the week and how sort of interfering in life they are, or how much effect they're having on the body physically. And then ARFID is one we're seeing more and more when there's been a medical complication from it. So I guess ARFID would have historically been known as the traditional picky eater or beige eater, which for a lot of kids is really normal, and that's a phase that they grow out of. So when we're thinking about it as a concern that might require treatment, we're looking for when there's significant weight loss or nutritional deficiency, which has stopped development in its tracks usually. So it's really key that there's no concerns about availability of food, or there's no active attempts at weight loss, concerns about weight or shape. It's just more purely focused on a difficulty with getting enough nutrition in. And often the young people we're seeing with this, that's become incredibly narrow, their intake. So it could be one brand of chicken nugget and one brand of biscuit, and that's it. And that's the kind of level of challenge we're getting into. Okay. Assessment. So quite a wide variety of things to think about when you're seeing someone, to just consider in the back of your mind, maybe could an eating disorder or disordered eating be involved with this? So commonly it can be other people around the person who start to notice concerns and raise concerns. With young people, there's some really common times that they present more in bulk. So it's often Christmas holidays when family who haven't seen them for a while see them and notice that they've lost weight. Coming back after school holidays, teachers might notice that. If you're in a clinic, maybe you haven't seen them for a couple of months and then you see them. So often immediate family are some of the last to pick it up because they're seeing them day to day and they don't notice the weight loss as acutely as people who see them less frequently. in children and adolescents, any kind of weight loss or just staying static, not growing in height. So anything kind of out of the normal developmental trajectory. Any acute events, so commonly people are dehydrated, there's electrolyte disturbances, hypoglycemia. It's very common that people present with other gastrointestinal issues. A loss of menstruation or kind of irregular menses is really common. So these are things that could occur for a multitude of reasons, and it can just be useful to check in around eating as part of them. An over-focus on healthy eating or some kind of change into particular diets, restricting particular food groups, that's new. Excessive exercise, that can be one of the really difficult ones to treat. So noticing if a young person's getting over-focused on exercise, and particularly outside of the team environment. So if it's that, say they're rowing, but they're also, 5 times a week, but now they're also going for a run every morning on their own and doing something else. So it's kind of going above and beyond what the team would be doing. It's really common for eating disorders to come up in people with diabetes, particularly young people with diabetes, chronic bowel issues, thyroid issues, and weight loss due to an acute illness. So it's a very common way that young people present is having had some kind of infection or gastrobug or something like that, and really struggled to regain some weight afterwards, and they've had then all the other risk factors for an eating disorder, and that's what may have kicked things off into an irregular eating pattern. And pretty much everyone we see presents with something else too. So the other one that's not on that list that's really common is PTSD as well. So as is commonly part of a comprehensive mental health assessment, checking in on people's food and eating and exercise, and trying to establish if that's is disturbed as part of whatever else is going on for them. So in the UK, some screening questions were developed particularly to help people in primary healthcare, as a way of asking just some actually really direct questions as part of a consultation, and then using those to gauge whether further assessment might be warranted. Do you make yourself sick because you feel uncomfortably full? Do you worry you've lost control over how much you eat? Have you lost more than, so in New Zealand we'd probably say about 5 kilos? Do you believe yourself to be fat when others say you are too thin? Would you say food dominates your life? So the idea is having questions like these in mind that are really direct, and asking about symptoms, and if you're getting a yes to any of those questions, to then investigate further from them. So this goes through what would be if we got a yes to one of those questions, think about we wanting to know more about what's going on. Being really kind of overt in the questioning is really important. So part of the way an eating disorder works is it works best when the person's being really secretive about it. So asking really direct and specific questions is really important. So generally people won't avoid necessarily answering those questions, but unless it's asked incredibly directly, it won't be answered in the full way that you need. So an example might be if I ask someone, what did you have for breakfast? And they say cereal, and say, what did the cereal look like? What kind of cereal was it? So they might say cornflakes. How many cornflakes? And they might say it was a teaspoon of cornflakes. What did you have with the cornflakes? Was it water or milk or another type of milk? So that level of detail when you're getting into the specifics of an assessment with someone is really important, because the initial answer, cornflakes, in my mind, that might be a full bowl with milk. but what actually took place was maybe a tiny drop with some water. So getting really specific about that. Same with binging, like I mentioned. So for some people, they might describe a binge as a packet of chips and think that that was a binge, whereas what we'd consider more a binge would be the chips and then the biscuits and then some bread, and then kind of, so needing to build a really specific picture of the amounts of food for a binge. So that's really the important first part, is getting a really clear picture of what are the symptoms that are going on. This is also really key because it's going to guide your medical monitoring and interventions, as we'll get to a little bit later. Thinking about that again with compensatory behaviour, so wanting to know if there's purging, if there's laxative use, and if there's exercise, is going to help you think about, for example, the electrolytes that might be involved in that are being lost. And then getting an idea of the thoughts and feelings that the person's having about food, how intense, how much of the day is that dominating. Goal weight can be really useful to understand. What are they aiming for? Is it really specific and really concerning to you? Or have they not really thought about that? And getting a gauge of their insight into what's going on. Do they think it's a problem? How much is it interfering in their day-to-day life? I'm going to go into the physical assessment a little bit further in more detail in a minute. Getting an understanding of what other comorbid mental health concerns might be going on. Most people will have some kind of mood fluctuations and anxiety. Thinking about risk, so suicidal ideation or self-harm are really common parts of eating disorders. And so making a bit of a plan around that with them. I'm not sure how widely the HEADS assessments are used, but that can be also a great way of kind of screening for eating disorders with a young person. It's kind of packaged within a more comprehensive assessment. And I feel like the eating part of the HEADS is kind of like the SCOFFED screening questions on the previous slide, and so that would be a way of kind of highlighting to you whether maybe a more comprehensive assessment would be useful. Medical. So we're going to look at anorexia and bulimia, and both affect pretty much all parts of the body, and in slightly different ways. So as we've looked at a little bit, we're going to see changes in the brain, and generally people with low weight are going to be quite rigid in their thinking, extremely fearful of the weight gain, irritable, often find it quite hard to connect with people and stay in relationship, and often families will be able to really clearly describe personality changes. They feel like the young person they knew has completely disappeared. We see hair getting really thin and brittle, often falling out, pressure on the heart, and I'll talk a little bit more about that in a moment. Usually lots of changes within people's blood work, weakening of muscles, and bone mass being lost. In the most extreme, we can see kidney failure, and issues with the liver as well. A lot of gastrointestinal issues, so constipation would be one of the most common problems, and that can take a really, really long time to resolve, even with weight restoration. Commonly, period stopping and hormone levels dropping. In men we see testosterone levels dropping, and skin and nails that's just all looking not well nourished, basically, and feeling really cold is another common one. So often, people coming in the middle of summer with 5 layers on, really struggling to stay warm. And then bulimia, some similar effects, and some key kind of different ones to think about. So body fluids would be a big one. So keeping an eye on dehydration, and blood work to be looking at electrolyte balances. You also see disruption in hormones. Again, slightly different, but some really concerning gastrointestinal issues. So you often see people that are getting, so it's kind of saying from the top, teeth issues, enamel erosion, difficulties with their esophagus, so tears or just irritated and sore, and then ulcers and pain in the stomach. So if we're doing our kind of baseline medical assessment, and this would be the type of assessment that we're doing quite regularly with someone once we've established we're concerned that there might be disordered eating that's having an impact, this would be our starting point. So we're wanting to do weight and height regularly, and thinking about BMI really in the context of that person. So a weight history is really important. So did they come from a higher body weight and they've lost weight? So the BMI might be 25. So like I was talking about, that they could still have anorexia at that weight. And same with someone with bulimia, we just might notice that fluctuating quite a bit. So more we're looking at weight in the context of that person, how much is it shifting week to week for them. To get an idea of what's happening cardiovascularly, we want to do a blood pressure and a pulse rate lying and then standing. We're looking for what's changing from lying to standing, if anything. Temperature, there's some debate around the team still about orally if possible, is one of our doctor's preferences, but there's lots of people who would say other orifices are just as accurate. Getting an idea of hydrations, often kind of a visual look for that, and in the history that we're taking. And muscle strength. So a common one, particularly in people with a low weight, would be getting them to squat down and stand back up and see if they're able to do that with enough strength, and are they able to kind of manage the balance there as well. So this is talking about when we've got low weight again. So the brain loses both white and grey matter when someone is in a state of starvation. And on the whole, we see the white matter return, but people can be left with some damage post-weight restoration. So notice people are really inflexible at a low weight and find it really difficult to engage in therapy. Often very irritable, struggling to focus and learn and engage with their peers, very preoccupied with food, and that's really what people describe as just kind of taking over their life altogether. So this was some of the brain imaging that's been done that just really shows that clear loss in the grey and white matter when someone's underweight. And that just it's a huge effect on the person and our ability to engage with the person. So it can really reduce someone's life down massively. Bone health is also one that we're hugely concerned about in young people, and the risk of osteoporosis. And we often see older people who we know of who've either recovered or still have an active eating disorder, who have real problems with bone fragility in their early 30s. And from what we can tell so far in the research as well, is that even quite a short time of restriction and weight loss can lead to longer term issues with people's bones. So always the kind of key message with anorexia in young people and weight loss in young people is as fast as we can restore weight, the better. It's the most important thing from both a psychological and a physical perspective. So just a little bit more about what osteoporosis looks like. It's good for scaring families into treatment. Blood tests, so we do quite a full workup to start with, and then depending on what the eating disorder diagnosis is and the behaviours that we're concerned about would dictate sort of going forward the bloods that we're checking. So for people with bulimia, the electrolytes would be one of the key ones that we're keeping an eye on. And in anorexia, probably some of the more kind of acute ones that we'd be thinking about would be glucose. We'd often see thyroid function staying low for quite a long time. It takes quite a long time to resolve. And we'd be checking hormone levels when someone's in treatment, probably every 3 months or so. That helps to give us an indication of where the weight is restoring. So hospital admission criteria is different all around the country, but it's quite useful as a guide for what a really kind of crisis urgent referral to a hospital might, what would indicate that might be needed. So this kind of helps you to think about the severity. So this is it's different even in Auckland between the 3 DHBs. So this will be different in every DHB, but they're not too dissimilar. So it gives you quite a good guide. So severity we're thinking about in terms of weight loss is someone being less than 70% of their expected total weight, or losing more than 20% of their body weight in the last 3 months. Any acute medical complications of malnutrition, severe dehydration, hypoglycemia, electrolyte imbalances. So the physiological instabilities we're looking for is a bradycardia. So in children, we'd probably be looking more like less than 50, adults less than 40. If they're hypotensive or there's a significant postural drop or postural tachycardia. Hypothermia, and particularly to be cautious of through the winter, that often people in our clinic, they'll be presenting regularly with hypothermia. In the initial workups, we would always do an ECG for someone as well. And then sometimes thinking about how significant the comorbid psychiatric risks are. So sometimes there might be disordered eating, but actually the suicidal ideation or self-harm, something like that, has become a real concern, and that needs addressing just as much as the eating disorder does. Okay, so thinking about how we support young people with disordered eating. So there's some key therapies within the specialist services that are offered. There's a range of individual therapies, and in our clinic we do adolescent parent treatment, and there's a couple of versions of this, and we use family-based treatment as our primary treatment. So the key in treatment really for young people is getting parents and caregivers involved as much as we can as a support system. We also find group work really useful for parents and young people to connect and share ideas and share what's working for them, share the woes of treatment as well. So we offer a range of things. Individual treatment would be our last choice because both in terms of illness and developmentally, it's often really hard for young people to engage and make enough change on their own. They genuinely need the support of other people around them. So the key messages of all these treatments though are we want to encourage people into eating patterns where they're having enough food, they're eating it regularly, and there's enough variety, and that goes across all eating disorders. That we're encouraging family to be involved as much as is appropriate and useful. Being really careful with our language and making sure that as much as possible we're trying to reinforce that eating disorders aren't a choice that people make and that they're not to blame for having an eating disorder. And anorexia, the key focus to start with is restoring weight back to a safe weight for that person. And in bulimia, it's getting regular and enough intake, and that is what's going to help to reduce the compensatory behaviours over time. So what can you do? So this is the first part, educating, understanding more about eating disorders, what the risks of them are and how they might present. Trying to use externalizing language when you're talking about it. So often we talk about the eating disorder as being separate to the person and often has a lot of control over the person. And that can be useful, particularly for families, because a lot of the behaviours that young people will start to show can be really infuriating, feel a lot like bad behaviour. And so helping families to distinguish what's eating disordered behaviour and what's their young person can be really useful to help them to stay calm. Regular medical monitoring for all eating disorders is really important. Providing resources to families. So I'm going to go through some of those shortly. So just being able to signpost people, it's really useful. Empathy and boundaries would be the key to a lot of the treatments as well. So the idea of sort of firm but kind. So there's some really important baselines around safety that need to happen, but we also understand that the young person's not choosing to do this. So we want to be alongside them, but also keep them safe. Reinforcing those key messages. So for example, in anorexia, that's really that weight restoration is the key to getting things back on track. And in bulimia, that regular and enough eating. Figuring out how you connect to the specialist services and those kind of options that you've got. I know a lot of the services provide a lot of consultation where they can out and around the community. And for yourself, if you're working with a lot of eating disorders, being conscious about self-care and supervision with that, because a lot of eating disorders are quite chronic, long-term conditions for people, and change can be quite slow. So as clinicians, that can be quite hard to sit with as well. So there's some of the resources that we use a lot. So FREED is a program that was developed in the UK, and it's a early intervention treatment for people presenting with eating disorders between the age of 16 and 24. But it has some really great resources for both professionals and families online. And a lot of the kind of really accessible information around the biology of eating disorders and some of the key starting treatment messages. SEED is the Centre for Excellence something in Melbourne, and they've got a really excellent 101 Foundations Introduction to Eating Disorders online program that you can do. So I think it's about 12 hours altogether, and it gives you a really nice overview, and we get all of our staff when they start in the service to do that as a starting point. And then they run regular Zoom trainings kind of over and above that throughout the year as well. NZ is the Australian New Zealand Eating Disorder organisation. I'm not sure if it's an organisation, something like that. And they really spearhead the research in the area. So they also run a lot of webinars throughout the year on different kind of subspecialty topics. Starship has some really great guidelines around the medical management of eating disorders. And the CCI website has some really great self-guided resources for people. So we often point people in that direction as well. And it can be really useful as a clinician. So often, like when we've got new grads coming through, we'll get them to work through like a self-guided workbook as a way of getting to learn some of the treatments. So families and caregivers, the externalization and trying to remove blame from the whole system is really important, because that kind of blame and guilt that can happen when an eating disorder is diagnosed can be really paralyzing for a family. Accessing education, so pointing them in the direction of where they can find out more. Supporting the young person with the regular monitoring, so often being available and being able to bring them to appointments is really useful. The firm but kind approach, and trying to, again, that's where kind of taking the blame and externalizing comes into play, to allow parents and caregivers to be able to keep those kind of firm boundaries and key messages in place, but also stay in a kind space at the same time. Open communication is really important. So eating disorders work best when things are secretive. So encouraging families to be really open about what's going on. Prioritising time for families to connect outside of the eating disorder. So sometimes getting into treatment and it can feel like eating is the topic 24/7, and it can be really destructive to relationships. So encouraging families to find time outside of that to connect about something that's not to do with food, which comes into the self-care again as well, prioritising time outside of the eating disorder, basically. So again, I would point families to FREED. There's some really accessible information on there, and the CCI self-guided workbooks as well. FEAST is an international family sort of parent support network for eating disorders, and they have a really quite a useful 30-day intro to eating disorders for parents, basically. So it gives an overview of what eating disorders are and some of the starting skills for them to support a young person. And then ed.org.nz is the website for EDANS, which is the New Zealand parent support service that runs throughout the country. And they are really great because there's kind of someone always on the end of the phone for a family to talk to, and they're all parents who have been through eating disorder treatment and have a recovered young person. So they're really great at giving really practical advice to families. They know the support networks throughout the country really well, and in some areas they run in-person groups too. And that is me.
Thanks, Harriet. A lot of information covered.
Yeah.
Short time, hey. Okay. I've just reminded people to post some questions. We do have one in the meantime. FBT, is that the Maudsley method Pauline was asking?
Yeah, so it was developed at the Maudsley as a family-based treatment, and then it was manualized by the American team at Stanford University. So they're not too dissimilar, and the main reason probably you'd hear more about FBT is because it was manualized, so it's easier to train internationally. So that was rolled out through New Zealand about 10 years ago now, and so all the main specialist services, that would be their primary treatment for young people.
So what is the correlation between eating disorders and its increased likelihood with type 1 diabetes?
What we tend to see is, I think, it's in a group of young people who often get really angry about their illness as they head into their teenage years. And so it might have been that they they were diagnosed at quite a young age, so like under 5, and it was managed by family really supportively, went really well. And then the trajectory we tend to see is they start to hand over independence to the young person, and mixed in with all their thoughts and feelings about the illness, they often start to realize by manipulating the insulin, they can manipulate their weight, which of course is extremely high risk. That tends to be the type of presentation that we see. And generally the young person's got a shortish history of starting to disengage with services and be harder to manage. And it's usually around the time of gaining independence as well.
Yeah. And Jane has come in with another question. Are EDs common in the geriatric community when not associated with other physical illnesses or dementia?
Not so much. Yeah, so usually the kind of most common time of onset would be under 30. Although we do occasionally get someone who has developed probably weight loss, but more in conjunction with a depression in that age group. So commonly like a loss of a partner, a long-term partner, or some kind of life stage depression has led to some weight loss. That would be more commonly what we see, but not commonly the development of an eating disorder at that age.
Thank you. And Revitere has asked, at what age can we start screening and treating these children?
I'd be starting to gauge the kind of family culture of eating at any age. It's quite common when we do a developmental history of a young person that there were eating concerns right from birth, sometimes even, that they were really difficult to latch and feed and transition onto solids. So those kinds of things can be a red flag. So it's, I guess, right from any age, there can be a chance for just education around picking up on what a family culture might be and providing some education about what regular eating might look like. Probably the youngest we would see with anorexia would be probably like 9 or so, with ARFID younger than that. Probably the youngest we'd see, they'd be like 7 or 8. And bulimia tend to be a bit older, into the early teens. But I think, yeah, it's often in a history that you find that there's been a sort of pattern of concerns with eating that have developed over time. So I think at any point there's a chance to inquire and educate.
Right. And can further trauma cause a relapse? And when can you say someone is better?
Good question. Yes, further trauma can cause a relapse. Relapse is really common. Recovery rates of a more severe illness are relatively low. In terms of, so say, for example, in family-based treatment in the manual, partial recovery is classified as someone restoring back to 95% of their expected healthy weight. And full recovery would be getting back to 100%. So it doesn't, a lot of the manuals and kind of research don't really talk so much about the level of cognition someone might still have. So we would see a real mix of recovery, and for people with a more severe illness, for a lot of them it becomes a chronic illness that they manage. And people manage incredibly productive and satisfying lives even with some degree of disordered eating. And other people make a full recovery and never have a whiff of it again. So with the trials that were done, the randomized control trials for family-based treatment, there was, I think it was about 70% partial recovery, 50% roughly full recovery. Sorry, no, that math doesn't work. 75, no, come back. No, it was 50% partial recovery with another 25%, 25% full recovery, and then you usually see about a 20% relapse rate. as
Oh,
well.
that's
So
interesting.
that's quite good.
Mm.
For CBT in adults with anorexia, it's a lot lower than that. So it's about a 50% with some kind of recovery, and 50% of that will relapse. So the family treatment is one of the most effective, getting it young, getting in early, and getting in with lots of support.
So you might have hit another question, but you might have hinted at it before. Does anorexia of infancy correlate with the development of anorexia nervosa?
So meaning like a malnutrition in infancy.
Does anorexia of infancy,
Yeah.
so if an infant chooses to stop eating or doesn't eat, does it correlate with the development of anorexia nervosa later on, I imagine?
Yeah. Sometimes I think, again, it seems to be that you've got to have the full kind of range of risk factors. So that can be part of someone's history, but I wouldn't say it was necessarily a given that they would develop an eating disorder later on. You tend to still need the kind of full package of some genetic loading, another period of weight loss later on, and some of the personality traits. But yeah, it's a really important gauge of someone's history when we're taking it as was this something that's been bubbling right from birth sometimes. Yeah.
Thank you. And we've got some more. Gosh, a few more coming now. What is the most appropriate treatment modality for a young person with ARFID?
ARFID would be, we usually do a family-based treatment as well. So it's very similar to the treatment for anorexia, and the major focus is on exposure. So it's very slow treatment, but it's very effective. So kind of just slowly trying to expand their range of foods and types of food over time.
Cool. And what are the different behaviours to look for in children with eating disorders? How do you differentiate with normal behaviour?
I think when we're looking at a diagnostic point, we're thinking probably mostly about how much impact it's having on their life from a psychosocial perspective and a physical perspective. So as I said, with all of us, there can be such a range of ways that people eat, but the concern is when it's impacting the physical body or it's impacting the person's ability to function.
Thanks. And the next one is, now, have you found some useful ways to encourage someone's engagement to receive support to deal with the ED?
That's a great question too. I don't talk about that enough, the ambivalence that generally comes with someone with disordered eating. Generally, I think our biggest focus would be on getting people functioning and back engaged in the world. So focusing on, it's not as effective to talk about the impacts this might have on them long-term or on their physical body as it is to talk about the impacts it has on their social world and education, things like that. So young people tend to not be able to comprehend that one day they might be infertile, or one day they might have osteoporosis, or they might end up damaging their esophagus. Those kinds of concepts are a bit too abstract and in the future. What's more important is things like, this is going to reduce your ability to engage in school and achieve, or you're not going to be able to go to the school ball, or how it impacts the kind of immediate world is usually more motivating. And persistence, often it can take months and months and months for us to engage a young person sometimes into kind of getting anywhere in treatment. So that medical monitoring kind of touch point check-in time can be really useful, is to just start to develop a really regular, predictable relationship with them and be the way to get further in treatment.
Thanks. And the next question is, have you found some useful ways to encourage someone's engagement in order to receive support to deal with the ED? It's a bit like the last one, really, isn't it?
Similar to the last, yeah. The other thing we often do is think about motivational interviewing techniques. So that would be a core training for a lot of our staff, and a lot of people have probably come across that already, and that can be quite useful. I think probably also just not being scared about asking the really direct questions, and although that young person might not come back to you for some time, starting to kind of highlight those concerns and ask things directly is still really important.
Thanks. And when we think of normal dieting, how much of that contributes to the risk of developing disordered eating?
It's really high risk for someone who's got the risk factors for developing an eating disorder. So weight loss can easily trigger an anorexia for someone who's got that genetic loading and the risk factors. And probably what's more prevalent would be bulimia and binge eating. And the mechanism in that really is the restriction of food causing someone to binge. So if you're thinking of dieting and any kind of restriction of calories, it's just more likely to encourage someone into a binge cycle. So there's kind of that part of dieting that really plays into contributing to the development of eating disorders if someone's got the other risk factors for it.
Right. Now we've got a few more quick questions. You okay for a few more minutes?
Yeah, that's all good.
And there's been a couple of questions that were quite sensitive and quite detailed. And did I hear you say that people could contact you?
Yeah, that's totally fine.
And did you show your email address earlier, or is it on your?
No.
Don't worry, just tell me what it is and I can type it in the chat.
Oh, cool. So it's just Harriet, Harriet.
Yeah.
At ADHB.
I knew this.
Yeah, true. We've been emailing .gov.nz. That's
very kind of you. I think for a couple of them, that's the best way to go.
Yeah, happy to do that.
Okay, so back to the more straightforward questions. Are there any medicines available for treatment of ED?
Good question. Nothing's got great evidence, but what we would commonly use in terms of psychiatric meds is an SSRI, because there's commonly mood and anxiety concerns, and often they can predate the eating disorder too, so that can be useful. In the acute phases of refeeding for anorexia, we often use olanzapine to manage people's anxiety and fear. In the adult continuum, there's some newer evidence around the use of aripiprazole for a first presentation of anorexia, so we've been using that with some really good effects. That's probably all, but as I said, there's not really good evidence for any of those having much impact. Yeah,
thanks. And how do you see many boys with eating disorders?
Yeah, not as many as we know are out there, definitely, but yeah, we'd see a handful at any one time. But yeah, we know from the kind of wider research that we should be seeing a lot more than we do.
Right, that's interesting. Oh, another one's coming just as I thought it was at the end. With patients, we'll make this the last one. With patients who have prolonged QT, how do you recommend supporting antihistamine use, stroke QT prolongation meds, when these can be bought over the counter?
Ooh, curly question. I don't feel like I'm the authority on that one. So if you could email me, I can get you a nice comprehensive answer to that.
Okay, there you go. There's another one for the email. Oh, another one. Do you find ED in menopausal women? Do we get that?
Not commonly, but again, it's not presenting to our services. So I think probably useful to remember is that the service I'm in is for the moderate to severe, and with the pressure on the health system, probably only the severe at the moment. So whereas we know particularly bulimia and binge eating is extremely prevalent out in the community, and it's just often not at a risk level that's being seen in specialist services. But I would at a guess say that disordered eating would be higher in that group because of the common weight gain that happens during menopause. So that wouldn't surprise me, but we don't tend to see it. Yeah.
Okay, well, that's it, I think. Thank you very much, Harriet. That's been, a really good Q&A session in the end, wasn't it?
Yeah, that was good. Thank you, everybody.
Really earned your money tonight. Thank you so much. A great presentation, and obviously very well received. Some lovely messages on chat there thanking you as well. So I'll thank you, and I'll thank all our participants for joining us tonight.